Hi, welcome back. So this lecture we're going to be discussing canine mast cell tumors, which is a very common tumor in dogs. The case that we're going to discuss is a dog named Maggie, a 5-year-old female spayed Labrador. She was healthy with no problems until now. The owners noticed a mass on her front leg 3 weeks ago. Since they noticed it, the mass got smaller and then returned to the original size. So what words do we want to use to describe a mass? Okay, so we want to see whether it's cutaneous or subcutaneous. Is it soft or hard? Is it well circumscribed? Is it diffuse? Is it painful? All sorts of words like this can really help us understand what we're talking about and help us to communicate it to another veterinarian that may see the dog the next time that they come in. So her mass was a subcutaneous, soft, well-circumscribed mass on the right front limb at the distal radius. And the most critical thing of all of this is to measure the mass. So we want to know with a caliper or with a ruler exactly how large this mass is so that the next time she comes in, we know whether it's the same size, whether it's larger, or whether it's smaller. So obviously, based on these physical exam abnormalities, we want to do a problem list and a differentials. So obviously the problem list is a subcutaneous, soft, well-circumscribed mass on the right front limb at the distal radius, and the measurements are 4 by 2 centimeters. The differentials are obviously our round cell tumors, sarcomas, and carcinomas. So of the round cell tumors, the tumors that would be most likely are a mast cell tumor, a plasma cell tumor, or a histiocytic sarcoma. The other round cells that we discussed were lymphoma, so the location would not be really appropriate for lymphoma, or a TVT, which also wouldn't really fit here. Sarcomas, it could be a hemangiopericytoma, a fibrosarcoma, an osteosarcoma, a chondrosarcoma, a hemangiosarcoma, but several of these would be much less likely because there's no evidence of pain or lameness. So chondrosarcoma, hemangiosarcoma, and even osteosarcoma wouldn't be likely. Carcinomas, the most likely might be a squamous cell carcinoma. So the plan, obviously, I'm sure you know it by now, will be due to a fine needle aspirate of this mass. And these are the results of our fine needle aspirate. You can see that this is a round cell tumor and a cellular aspirate. And these round cells obviously have granules, many granules, here and here. And this is diagnostic for a mast cell tumor. So what are mast cells? So mast cells are derived from hematopoietic precursors, and they're found in the liver, lung, skin, GI tract, and bone marrow, and they're integral in inflammatory and allergic responses. Here again, another picture of cytology in a mast cell tumor. So these mast cells, these granules can either be more purple, more pink, more red, depending on the way that they're stained. Mast cell tumors are the most common cutaneous tumor in dogs. The etiology is unknown. There is an increased incidence in some breeds, so there may be a genetic component that hasn't been proven yet. The mean age is 9 years, so more in older dogs, but it has been reported in younger dogs. There's no sex predilection, and the breed predilection is this tumor is seen more often in boxers, bulldogs, terriers, retrievers, and Chinese Shar-Peis. The history and clinical signs, we can just see nodules noticed by the owners, or we could see a dog that is really sick due to release of histamine and heparin. The locations can be anywhere in the body. 13% have been reported in the head and neck, 30% in the thorax and the forelimbs, 40% on the abdomen and hind limbs, and 18% in the genital and perianal areas. 10% of these dogs have multiple cutaneous tumors, and some may have systemic mastocytosis, which has been shown to be associated with cutaneous tumors. One of the first reports about multiple cutaneous mast cells was in 2004, and a retrospective study was done to define the biologic behavior, prognostic factors, and treatment outcomes in cases with multiple mast cell tumors. So what they found was that about 10 to 15% have multiple simultaneous mast cell tumors, and 47 dogs were included with at least 2 tumors. And their conclusion was that they have a low metastatic rate and appear to have an overall median survival time and disease-free interval similar to low or intermediate grade solitary primary mast cell tumors. So this study showed that even if a dog has several tumors, it's not a reason to say it's all over, we have to give up, and we can't try to treat them. So even in cases with multiple mast cell tumors, we want to try to help these dogs. So obviously the first step in any case of a tumor is getting a diagnosis. And we can get a diagnosis in these dogs most often with an aspirate. Sometimes a biopsy is required, but most often if we do an aspirate, then we're okay, and we know that as first step that we have a diagnosis of a mast cell tumor. So then what? What are we going to do now? The second step we said is staging. So what staging is needed in canine mast cell tumors? Do we need to do everything? Do we need to do minimal staging? A lot of staging? So that is kind of controversial, and it really matters on the dog, on the specific prognostic factors for that dog, whether it has systemic signs, the tumor locations, and of course on the owner. So let's discuss now whether we need minimal or complete staging. So we're going to discuss what complete staging is, and then when we need minimal and when we need complete. So complete staging obviously includes a CBC, KIM, and urinalysis. We need this minimal database prior to surgery, just for anesthesia reasons. Possible abnormalities we may see on the CBC in dogs with mast cell tumors include eosinophilia due to chemotactic factors and IL-5, anemia second to hypersplenism or GI bleeding, and we may even see mast cell tumors circulating in the blood smear. The second test, which is critical in any dog with a mast cell tumor, is lymph node evaluation. So if we're discussing minimal staging versus complete staging, the only test that is critical on minimal staging is lymph node evaluation of the regional lymph node. So the pros for this test is that it's non-invasive and inexpensive. The cons are that in some of the cases it's difficult to interpret because we're not sure whether the mast cells that we see are because of draining from the tumor or actual metastasis. So in order to understand that, you have to compare the differentiation of the mast cells in the lymph node and in the tumor. But this is the only test that needs to be done when we're talking about staging for dogs that do not require complete staging, but minimal staging. Additional tests that are done in cases with complete staging include abdominal ultrasound and thoracic radiographs. In the thoracic cavity, we might see lymphadenopathy, sternal and hilar, pleural effusion, or anterior mediastinal masses. In the abdominal cavity, we can see a splenomegaly or hepatomegaly. So the question that people ask for quite a while is if you do an abdominal ultrasound and you see that it is normal, is that enough? So in 2019, it was published that an ultrasound is a poor predictor for early or overt liver or splenic metastasis in dogs with high-risk mast cell tumors. So they actually showed that it isn't enough just to do an ultrasound, that you also need to do aspirates. So what they said was that conflicting evidence exists regarding the importance of routine abdominal ultrasound with hepatic or splenic fine needle aspirates and the fine needle aspirates during the staging of canine mast cell tumors. In this study, this objective was to correlate the ultrasonographic and cytologic findings in dogs with high-grade mast cell tumors and to determine the influence on the outcome. So they hypothesized that ultrasound poorly predicts visceral metastasis in high-risk mast cell tumors, and that early metastasis is associated with improved outcome when compared to overt metastasis. So they did the ultrasounds of the spleen and liver, and compared them to the cytological results. In their study, they had 82 dogs. 18 had early visceral metastasis, and 7 had overt metastasis on cytology. The ultrasound was found to be a poor predictor of metastasis, with a sensitivity, specificity, and positive and negative predictive values of 67%, 68%, 21%, and 94%. And for the liver, it was similar. So the median time to progression for dogs with no metastasis, early metastasis or overt metastasis wasn't reached, 305 and 69 days. So basically what they said is that high-grade, panic or cubal-grade, early metastatic, overt metastasis, and inadequate local control were significantly associated with outcome, and early visceral metastasis was associated with a poor outcome in dogs. So here we can see the results, that ultrasound is a poor predictive of early or overt liver metastasis. And here we can see the Kaplan-Meier curves showing survival times in dogs with no metastasis, early metastasis, and overt metastasis. So for dogs without metastasis, the median survival wasn't reached, while dogs with early and overt metastasis, the median survival was 322 and 81 days. So we can see here, here, and here. So what are the pros and cons of splenic and liver aspirates? The pros are that they're supportive of metastasis if present in organs with abnormal architecture. And the cons are a low yield if the spleen appears normal, difficult to interpret, invasive, and expensive. Buffy coat smears. The pros are that they are inexpensive, non-invasive, and supportive of systemic mastocytosis if the clinical signs are present. The cons, obviously, that they're low yield and difficult to interpret in low dogs. In general, we do not do Buffy coat smears. If we think that something might be wrong, then we'll go right to a bone needle aspirate. The bone marrow aspirates, the pros are that they're supportive of systemic mastocytosis if the clinical signs are present, more specific than systemic mastocytosis than Buffy coats. Obviously, the cons are that they're expensive, invasive, and low yield. So what are the prognostic indicators for dogs with mast cell disease, and how can they help us decide whether to do complete or minimal staging? Some of them can help us because we see them straight away on the dogs, and some of them can't help us because they're only information that we get after the surgery. So the first historical decider on prognosis for dogs